As of now, this event is being recorded, and we are very much looking forward to the conversation. I'd like to welcome our distinguished panelists, and we will begin today by asking you to use the Q&A function to pose your questions. After each panelist's intervention, we will be going to the Q&A function, and we very much look forward to hearing from you, getting your thoughts, getting your questions, and getting your ideas. I'd like to turn it over right now to James Campbell, Director of the Health Workforce Department, to kick us off. Jim, if you could start us off.
Thank you, Catherine. Good morning, good afternoon, good evening. And just to put those up there, I can see that we have participants from east to west, from north to south, Brazil, Canada, US, Australia, Philippines, South Africa, many of the countries in Europe. Good afternoon, welcome to you all. Obviously, a lot of interest in this topic, and it is work that we have been developing for a little period, over 3 years now, and with a fantastic expert network from all countries, north and south, east, west, high income, middle income, low income, that have been really contributing to this period. We're going to have a series of presentations today just to give you the updates, and we'll be going into more detail over the next couple of months on this work, really looking at some of the technical areas and how to drive this forward to have an impact at the country level. We're going to have some discussion momentarily from Siobhan Fitzpatrick, who's led this work, and then Rajiv and Adres will give some perspectives on this. We're having a slight technical hitch with Adres's connection at the moment, but we hope that she will be available to join and give some of her perspectives shortly. I'm going to take a big step backwards, though, before we go into that detail, and just put this work into the context of WHO's activities. Next slide, please. We all know the COVID-19 has had a significant impact on the health and care workforce, on the delivery of services, on mortality, on infections, on so many different impacts across our population, the socio-economic disruption, the digital divide that we've seen. We've been tracking that from the workforce perspective and really looking at some of the issues. We know the level of infections, the level of deaths, the impact on mental health, the stress, the anxiety, the burnout. We know the number of protests and labor strikes with regard to the terms and conditions of employment. We are very concerned that some of these measures, this 2 and a bit years now of intense work under really stressful conditions, is going to have significant impact on intention to leave the profession. It may have impact on migration. It may have impact on early retirement. And it's definitely having an impact on education and our pre-service work. And we have to anticipate exactly what this impact might be on our capacity of our health and care workers to be able to meet the ambition of universal health coverage, the ambition of health security and the essential public health functions. Next slide. We're seeing already from countries that the lack of available health and care workers, either through these, the impact of COVID or the pre-COVID impacts and shortages were there before, is the single largest barrier to the delivery of COVID tools around the world. Everyone has realized that without the people in our health and care systems trying to add more work to existing schedules is going to be a challenge. Next slide. As a result, what we're seeing is that the vast majority of countries are actually saying we have to do something about really reviewing our workforce capacity. We have to look at our education models. We have to look at our lifelong learning models, the skills, the distribution, the competencies of these people. And why is this additionally important is because the economic scarring, the impact of the pandemic on socioeconomic conditions, on fiscal space, is likely, and this is evidence from the World Bank and the International Monetary Fund, is likely to reduce the potential public health expenditure for health, education, and social protection. Many countries will be servicing extremely high levels of debt, their economy will not be hitting the GDP growth that they anticipated, and therefore public expenditures will be rationed in the next few years. It therefore is an onus and a responsibility to look at what opportunity is there to support the existing workforce, to really further enhance and optimize their skills, their competencies to deliver services to all who require them at need. Next slide. To do that, we come back to our health labour market framework, which starts with education. And it starts with understanding how we connect our education sector, our education market with the health labour market. And how do we inform and influence standards, quality, normative work, competency-based education, the regulation, rural development, with looking at the evidence of how we really drive social accountability into the policies and plans at the national level. So it really comes back to this education emphasis. Next slide. That education emphasis is in the global strategy on human resources for health, in terms of making sure that we optimize the existing workforce, that we make sure that they have the skills and competencies to drive improvements in the quality and quantity of health services, but also anticipate future needs for the workforce, the population demands, and make sure our education systems are fit for purpose, that they are producing graduates that can immediately have an impact with their practice and their behaviors. Not graduates who are uniquely knowledgeable on every issue, but actually have the competencies to do the practice behavior. That same element driving further forward in a new action plan that will be at the Assembly in a few weeks' time for consideration, and really links this education employment debate and asks that we take this forward for the remaining period of 2030. Next. And at the heart of this is work that has been around for many years, that many of us know and discuss. WHO's publication in 1978, when some of my team were not yet born, really sets out some of the early thinking in this domain. Then, of course, the seminal work in 2010 by the Lancet Commission to really enable, and again, this evidence is really underpinning, but in addition to that evidence, that academic literature, the actual practice and behavior and literature really supported by this expert network who are doing this work on a day-to-day basis, and really therefore helping us bring the best in practice evidence of what works where, under what context, to this debate. Next slide. And so today it's really proud that for us to launch 3 new products on using the competency-based education framework to look at the outcomes. And in particular, we demonstrate an additional module which goes into a area on HIV to be able to start to inform and influence the national policies and plans. Ladies and gentlemen, colleagues, it really is an exciting moment, and I'd like to once again congratulate the team that have coordinated this and every single expert that really has given their time, their intellectual capacity and their experiential knowledge to WHO has processed this last 3 years, without which these guidelines are not living documents. They're something that we'll take forward. So with no further ado, Catherine, back to you for the next introduction.
Thank you, Jim, for setting the scene. We're now going to turn over to someone who has dedicated so much time and attention to bringing this document and this set of documents to life. Siobhan Fitzpatrick is a technical officer with the Health Workforce Department, and I'm sure all of you will very much enjoy her overview of the Global Competency and Outcomes Framework. Siobhan, over to you.
Thank you, Catherine. And it is a real pleasure to be able to, and privileged to be able to share the work on behalf of the working group and of course, on behalf of the WHO Health Workforce Department. So when we talk about competencies towards the achievement of universal health coverage, we're talking about the competencies of individual health workers. What is the contribution that as an individual health worker, they can make towards the achievement of universal health coverage, and how best can education programs prepare health workers for practice? So with these documents, with these frameworks, we really wanted to be able to provide guidance to educators, to those involved with curricular development and delivery, in terms of how best to develop and deliver competency-based education, but really harnessing that role, the potential of health workers with a 12 to 48 month pre-service training pathway. We really focused on these roles because we found that they were cohesive in their sort of role responsibilities, but of course they are only able to provide the services towards UHC within teams of supportive supervision, referral, and other occupational groups. We were ambitious in our scope. A single framework, to our knowledge, this is the first time that there is a single framework of competencies that is relevant across occupations, across different health services, across languages, different countries, different practice settings. So we very much wanted to focus on how this would be used to inform education, to inform employment. And in so doing, we really harnessed one of the principles of competency-based education, the modular approach. So we have focused on what are the functions and the services to be provided rather than who would provide them. But also in this single framework, we've harnessed the wealth of literature already available on competency-based education to provide clarity on how we interpret competency-based outcomes and conceptual and nomenclature clarity as well. So looking at that graph, which we know so well from the Lancet Commission, we are publishing today a framework of the competencies and outcomes, that middle block. But of course, in order to do so, we needed to understand the health needs and the health systems needs for universal health coverage. So we harness the wealth of information already available, the foundations for UHC, the UHC indicators, the strategic documents, the priorities, but also what actually does UHC look like? What does that mean? And some of the principles that are inherent throughout our work, the emphasis on quality. UHC without quality in health services is a job half done. So the quality, what does social accountability in education look like? How can individual health workers incorporate a human rights approach to health in their practice? What contribution do individual health workers make to challenging the determinants of health? So we started from that, but we also started from the foundations. We are building on the giants in competency-based education. There were more than 300 frameworks that we already identified in different areas, looking at the competencies, perhaps for a specific occupational group or a specific service area. We looked at role descriptions, the International Labour Organization's ISCO, which is the categories of activities for different health worker groups. And of course, competency-based education itself is not a single concept. So we also wanted to look at actually what are the merits of competency-based education? How in a framework can we harness that potential? And how can we address some of the limitations or challenges in implementation? of competency-based education. So there was an immense amount of content analysis and looking at actually, is this knowledge, is this impact, what does this mean for an individual health worker? So evidence in health worker education is, of course, implementation. It's based on best practice in terms of who is doing what where on expert judgment. So fundamental to our work was consultation. We're indebted to the work of an education working group who provided us with their technical expertise and guidance throughout the process, but also the consultation with the members of the Education Hub, with individual member states, with country offices, with different interest groups and health workers from across different geographies and settings. We carefully approached the competency model, which is the foundation for this framework. We're mindful of how the framework will be used to inform employment and education. So of course, the ultimate goal of health worker education is a health worker who is competent to provide health services. But taking a step back from health services, it's the activities and tasks of health services that an individual might provide as part of a team. So the practice activity is the ultimate focus, the sort of the area of certification or the unit of credentialing, what you might see in scope of practice, but their competencies are what enables them to perform those practice activities. So the competencies are the behavioral attributes, but of course we need to focus not only on what is done and how it is done. So we take that holistic look of competence in the competency frameworks. Of course, from an education perspective, we think about the learner journey. To get to that ultimate goal of application of knowledge, skill, and attitude, we need to develop programs that incrementally enable learners to develop that knowledge, to apply that knowledge, to develop the competencies to perform practice activities as required for the context. So now to the content of the framework. Chapter 2 of the Global Competency and Outcomes Framework outlines the 24 competencies that we believe within WHO are essential towards the achievement of universal health coverage. So to achieve that quality in health services provision, we find it essential that health workers have competencies in people-centered care, in collaboration, thinking not only about collaboration with other health workers, but collaboration with the individuals and communities. We've also identified competencies in interpreting evidence, in decision-making, things like clinical judgment. So of course, these are not linked to individual services, but in fact, they enable the provision of all services, all practice activities. And in fact, there is very little that is new in this framework. When we compare this to existing documents, we actually found around an 87% overlap with other competency frameworks, but bringing it together, these are the commonalities across occupations. So we found this convergence, and within the framework, we have expanded upon what does this look like? How do you know if somebody has these competencies? What are the behaviors that they demonstrate in practice? As we keep saying, the competencies enable the performance of practice activities. So we haven't within the framework said these are the tasks or the practice activities that all health workers can provide. Instead, what we have done is presented almost a menu of the different practice activities that might be part of a person's job description or part of their role responsibility within a team. So within the framework, each practice activity we've illustrated with occupational profiles, we've provided example groups of tasks that might belong together, and provided these with also knowledge guides to enable the development of competency-based curricula. Within the practice activities, we did want to specifically draw attention to some of the areas of work that are often overlooked in education programs. Not everything that a health worker does is necessarily licensed or regulated or part of a scope of practice, but they are essential to the provision of care. Things like providing a handover within a clinical team, things like assessing community health needs, as we have seen so clearly with the COVID response, being part of that emergencies preparedness and response is very much part of a health worker's role, but not necessarily always part of a pre-service curricula. So again, within the framework, we've identified what those practice activities might be that are the outcomes of pre-service training pathways. The ultimate goal, of course, of pre-service training is competent health workers, but it depends on context. Competence itself is multi-dynamic, multi-dimensional. And like we've said, we need to focus on what is done and how it is done. So when we're taking these outcomes and interpreting that into competency-based curricula, we really think about constructive alignment. So we're thinking about the education outcomes, so during the competencies and the practice activities from the global competencies and outcomes framework, but also then identifying learning opportunities that enable learners to develop those competencies and the skills, the knowledge, the attitudes. So things like interprofessional education, clinical experience, but we also need to think about the assessment of competence. So assessment in situations where they will be expected to practice. So this does require a whole of program approach to translating those competency-based outcomes into curricular programs. We really want the framework to be used. So we have emphasized that throughout, rather than using the framework as a statement of this is what a curricula should contain. We've assumed that users will be able to start from, here is our service package. This is the scope of practice I'm interested in, the level of supervision, the practice settings. For that defined outcomes, for that defined set of outcomes, we can then use the framework to identify actually what are the knowledge that somebody will need, what are the competency-based performance criteria to provide those practice activities. But then additionally, can we use the framework as a reference? Is there anything else that we've missed that is part of the role that might not necessarily be related to a specific service? And of course, the ultimate goal is then competent health workers who are equipped to provide the health services for UHC. My colleague Jim Campbell mentioned earlier, we are also publishing the HIV module, and this is one of a number of accompanying modules which we will publish incrementally to highlight the specific service areas. So if we have an area like HIV services, how can we ensure that HIV is reflected within competency-based curricula? So taking that same approach of the previous slide, starting with, we know that these are the services, this is the scope of practice. So from a service, we then break down what are the tasks that an individual health worker might provide. So for some health services, this is a sort of a one-to-one provision of condoms, for example. It's a single task provided by a single health worker. But then you get into something more complicated where you need multiple health workers, for example, voluntary male circumcision. You might need multiple health workers to do so. So it's identifying what is the component of that individual health worker within the team. And then you can use the framework to say, so what are the knowledge guides? What is the competencies to provide those tasks? And my last point is very much an enormous thank you on behalf of the Health Workforce Department to the huge number of organizations, groups, and individuals who have shared their time and expertise with us so generously, and particularly the Education Working Group whose photos we have included here. So a very big thank you. We offer this framework as consensus across the many hundreds of individuals and organizations involved in the development and validation, as consensus and best practice in competency-based education, but also consensus on what the competencies are for health workers towards the achievement of universal health coverage. Thank you.
Thank you, Siobhan, for that intervention. We're going to go next to the country of India, where we have the distinguished Mr. Rajiv Sananandan. And please excuse me, I'm doing my best. You've got a beautiful name and you've got an even more beautiful intervention. Rajiv, I turn it over to you.
Thank you, Catherine. I'll share my screen. Yeah, thank you. The most of the presentations that has happened has been focusing on education. I'm going to change the tack a little bit because attending this presentation, there are educators, there are also people who work with health systems. And what I'm going to cover is the impact these guidelines can have on the health systems, on the role of human resources for health in health systems. As we all know, the most important building block that WHO has come up with is the human resources for health. One study carried out for a WHO working group calculates that 60% of the government expenditure on health is used to pay health workers. When managers plan for a certain health outcome, along with infrastructure, along with consumables, medicines, they also work out the number of doctors required, the number of nurses required, and so on. But as most of the planners attending this workshop know, the planning often takes place in terms of categories and numbers. And when the program goes ahead, you find that these are not leading to the desired outcomes, as the persons we have hired may lack the competencies, including clinical, communication, collaborative, and leadership ones to deliver the needed health outcomes.
I'm so sorry, Rajiv. I don't see your slides right now. Could I ask you to share your screen, please?
Okay, let me try it again. Are you able to see my screen now?
I have the slides here and I'm happy to share screen again.
Can you please? That'll be great.
Of course.
Yeah. Thank you. Okay, can you go to the next slide? I think I have the next slide, please. Yeah. So no, the one before this. Yeah. Now, the importance of this document for the health system is that it can bring out to the attention of policymakers that while health professions are needed, also need to work on their competencies. Next slide, please. Now, for managers, what does defining competencies do? As was mentioned before, competencies are never done in the vacuum. It's all defined in relation to outputs that we need to expect the quality care. So when you adopt a competency-based training, managers have first to define the tasks that have to be done to achieve these results. Now, quite often we look at the clinical activities, but this will also persuade you to look at communication, on training, on collaboration, on leadership, and disaggregate the knowledge, the skills, and the attitudes that are expected from the workforce. Now, while competency-based education is important, in the systems that we work with, most of the workforce are already in position. The problem then is that we have to assess the adequacy of their competencies. We have to define them, and they have to be supported to acquire them, and these have to be validated in the process at work. As has been coming out in the Q&A, the questions that have been coming up, mostly persons attending this workshop realize that there's a lot of work to be done before the guidelines can be kind of contextualized. So this helps the managers and also helps others to carry out this process. Now, next slide, please. Now, what can these guidelines do? In fact, there's always been requests for the tools to be shared, and I hope that will be clarified as we go along. These tools can help managers de-link task accomplishment from formal certification. If let's assume that in situations, adequate number of qualified persons are not available, and if you can identify people who then competency-based training will enable them to carry out the task even if they are not formally qualified. And in many of the low and middle income countries that we come from, this may be needed as formally qualified persons may not be available. So in such a situation, if competencies for the work are well defined and the assessment and training tools are available, managers don't have to wait for formally qualified persons to come. They can start trying to build the competencies to carry out the work, with the result that the impact of the shortage of qualified human resources for health can be minimized. God forbid that we have another pandemic. As we saw during this pandemic, the biggest challenge that we had in improving the search capacity was the lack of adequate number of human resources, because one, they get affected, their family members get affected, and then going forward, and normally in such situations we deploy people from other parts of the country. But if you have a situation like what we had this time, when every place get affected, that option is also not available. Hopefully, as we prepare our health system to become resilient for the future, if we can identify the competencies that are required for supportive care, because our experience is that if we have a virus, that a pathogen that we are naive to, then at least the initial stage, only supportive care will be possible. So if the competencies needed for supportive care can be identified in advance, and we prepare the tools, the digital tools and so on, that can be used to build it, then that will be one of the ways of making the health systems resilient for the future. Next slide, please. So the almost all the documents that we have been talking about emphasize the importance of primary care. But we know that except in the high-income countries, many low-income countries, PHC is generally staffed by generalist personnel. I mean, in the high-income countries, these are qualified specialist positions. But in many of the situations that we come from, this is staffed by the generalist personnel. And in an assessment that we did of a health system, we found that one of the reasons that that PHCs do not provide good quality care is because the teams lack the knowledge, skills, and attitude to deliver quality quality care. With the result, what happens is that populations lose trust in primary care providers, and they bypass the PHC for secondary and tertiary care providers, and in the process, which makes the health system inefficient, and we call that the reversal of the pyramid, and that is bad for the health system. If we are able to define, if we're able to assess the competencies that are required, and we are also able to build competencies needed for PHC, this can improve the positioning and quality of primary care services, in the process improving the trust of people in primary care, and also improve the linkages with other levels, because primary care on its own will not be adequate. You need adequate service also. Next slide, please. Yeah. Now, it also works on workforce satisfaction, because when people get clarity about what they need to achieve the planned outcomes, they're able to upgrade the services, and nothing makes us as happy as getting results. And this will add to their workforce morale. And for a highly motivated staff, because most of these will in future will be run as self-run modules, they can improve their capacity, often going beyond what the system expects from their role. Next. Now, this I've already covered this. The competencies do not exist in the vacuum. They have to be made context specific, and it will depend on the nature of work, the culture, the nature of communication, and so on. And it could differ from place to place, even within the same country. My request to the WHO is that if countries can be supported to adapt this document, it will be good. But as an organization that is trying to do in our context, I can assure you this is going to be a long and iterative process, but it is worth it, because both health systems and the healthcare workers will benefit from competency-based training. Thank you.
Rajiv, thank you so much for your very nice intervention. I now have the pleasure of introducing Address Malata, coming to us from the great state of Malawi. Address, we're really looking forward to hearing from you.
Thank you. Thank you very much, and thank you very much to all speakers that have already given their interventions. And I would like to sincerely thank WHO for inviting me to make a statement on this important event. And having gone through the process myself, really briefed this afternoon here in Malawi or morning elsewhere, to share my perspectives of what the Global Competency and Outcomes Framework can do for UHC. And my theme is implementing competency-based education. And my reflection starts with, at the end of the day, we want to see a successful implementation of universal health coverage. And I think the framework does provide the opportunity to build a stronger health workforce. And then, of course, for us to have a stronger health workforce, we need to build a health workforce education that's vibrant, effective, efficient. And of course, for us to achieve that, I personally believe, and having gone through the process of this development, is that competence-based education is key to ensuring that we have a stronger health workforce. But at the same time, the framework was developed from evidence that's really very good, that's really, people can question the evidence is there, and we know that what we have developed, what WHO has developed is actually can answer to questions. And therefore, at the end of the day, we would want to see quality improvement, care provision at every level in every society, and of course, every context. And I think I like the fact that the framework addresses the issue of context. It doesn't matter where you are. It can be used, it can be adapted, because it has actually encompassed all sectors, all circumstances, and all backgrounds. So thank you very much. And we move to the next slide now. So as I reflect on the framework, one other issue that is very important to note is that there are now opportunities, but of course, there are always challenges, but opportunities that we can use using the Global Competency and Outcomes Framework. And first is the fact that the framework does provide education that's oriented to expectations of the graduates. After school, after education, they go into practice. Can they use the skills, the knowledge, the attitude they have gained using this framework? Yes, the framework does answer that question very well. Orientation to the expectations of the graduates. And of course, it's also very effective tool for the approach to education design, because we know as we design programs, as we develop new curricula or revise curricula, you need to have a very good approach, a very good design that will help you push into a graduate that's comfortable with a practice in every sector. So this framework, the Competency and Outcomes Framework, does answer that question, approach to education design. So all those that are involved in development of programs have something to use. They don't have to start from the beginning. And of course, it's rooted in best evidence for education design. As I said earlier on, evidence is always critical, because people always ask, do you have evidence? The framework has been developed from evidence that can be answer to all issues that are affecting us. And therefore, we are very confident that the Global Competence and Outcomes Framework can be utilized in development of curriculum, designing and development of new curriculum, revising curriculum. But also much more important is the issue of social accountability, because we need to be accountable to the public, accountable to societies, accountable to communities, accountable to governments. This framework has got that ability to also show that, yes, we are socially accountable. And I think for all educators, this is something that we all look into. We want to make sure that there's accountability in whatever we do. And I think I talked about curriculum development and design earlier on. You don't have to start from nowhere. You have something you can use. For those of you who want to develop new curriculum, or those of you who are revising curriculum, these two can actually be used. You don't have to start from the scratch. And finally, quality improvement is everything that we are all ascribing to see at the end of the day. I think one thing that I also realized looking through the competency-based framework that's been designed is that there is a holistic approach to program development. So it's not just one part, it's holistic. And that is what we need to ensure that happens, because you cannot achieve quality education, quality products, if you're only looking at one aspect of education. But this is looking at the theory, it's looking at practice, it's looking at attitude, it's also looking at every other aspect of education. So the holistic approach is very important for re-engineering competence-based education. And of course, at the issue of alignment to population needs, alignment to the healthcare system in every setting. And it has got those principles that can be used and very, very important for re-engineering competency-based education. And of course, the main issue for the graduate is how do they transition from education to practice? A very difficult issue, because many times everybody thinks, yes, they've gone through the content, they've gone through practice as they went into clinical area, but at the end of the day, they graduate, they find themselves in a rural setting, in a little hospital somewhere on their own. Can they transition easily? And this framework does provide for that transition, which everyone is looking forward to. Next slide, please. And then, of course, context matters. And this is something that I have passion about, because many times people think everything works well everywhere, very well. But WHO has provided this framework that actually looks at the context about teaching and learning resources and equipment, what's available. So if you have limited resources, the framework does help you with the limited resources to still come up with a very good graduate. And of course, it also provides for occupational scope of practice. So you know the scope of practice, because we have different, professions, different occupations, but the scope of practice is properly provided for. So you know that for this particular occupation, this is how far you can go. The same with service packages, because at the end of the day, each of the professions is providing a service. They've got a package. The context we're talking about is the fact that it does also provide a framework guidance for service packages, and also guidance to the faculty, because faculty have to look into how best they can provide this education. They need guidance, and the framework has got that guidance, and of course also provides guidance on level of supervision, because supervision is critical for any provision of care and also critical for quality of care. Next slide, please. And then I want to zero in on curriculum design and development, because this is where I belong. So the framework does provide references for key outcomes, because outcomes are critical for competency-based education. We know outcomes really measure what the student has been able to do, or the graduate has been able to achieve. So the framework does provide that reference for key outcomes, which you can use, but also provides for structure that is utilized or is required for assessment of competencies. And of course, I've already talked about focus and then the holistic approach. So for curriculum design, I would really encourage those of you who want to even develop new curricula or revise that this would be a very good framework for you to achieve that in a very effective manner. And the framework I've talked about being holistic in the previous slide. We are talking about theoretical content here, clinical experience, we're talking about assessment, and the framework does not only look at the student, it looks at what faculty can do, and of course, what the institution's responsibility is, making sure that you actually come up with graduates that are very competent when they go out to practice. Next slide, please. And then, of course, the question is, does this help us to achieve universal health coverage? And we are saying yes. If you look through the whole framework, this is what we need for educators, for students, and for systems. And the whole education trajectory, if you do not use such a framework, what would happen is you'll be sorting one problem and then you see there's another problem. But this framework actually does provide for a person's abilities to integrate their knowledge, skills, and attitudes in performance of the tasks that they have to perform as health care workers. And this is what we all need in every setting. And I would want to encourage that indeed that many institutions institutions can adopt it so that you can actually improve. And remember, at the end of the day, the issues about quality improvement for healthcare provision, but also I think the specific issue I want to emphasize is the fact that it does address, population needs, but also address the health systems in status of any setting. So it doesn't matter whether it's high income, low income, medium income, according to the resources that are available. The framework does give that direction where you could actually use in any setting. I think that's what I like, because it does look at what you have, what you don't have, but at the same time making sure that you are acting within what is available in your setting. At the end of the day, it's about quality improvement. At the end of the day, it's about provision of care to the people, and that fact that people should be satisfied with the care that is provided by the graduates. So I think let me stop there, and we'll take any questions, any comments that people may have. But remember, we are aligning healthcare education with population health needs and health system demands. Thank you very much.
Professor, thank you so much for your intervention. That was just magnificent. It's really a pleasure to moderate such a distinguished panel today. And I'm very excited to see so many questions and answers in the Q&A section. And also just wanted to take a quick moment to recognize how many of the contributors to the Global Competency and Outcomes Framework development are currently present in the audience. We certainly benefit a great deal from your inputs. And as Siobhan noted, it's almost impossible to put all of your names on the screen and for anybody to read it quickly, but I hope everybody will take advantage of looking into the document, the summary document, which will be posted on our website quite shortly. It's fresh, hot off the press this morning. So we're very much looking forward to sharing that. With that, I'm going to turn very quickly to Siobhan, and I'd like to encourage you to keep your answer relatively brief, given our short period of time left. Siobhan, this question actually comes from our audience. Do you include interpersonal capacities and qualities in your definition of competencies and skills? These are among the factors and facets that are most valued by patients when evaluating the overall service user experience. And we also know that they often impact the outcome of different health interventions. There's also a quick note on mental health support and leadership alongside education. Siobhan, I'd like your response to this.
Yes, absolutely. So within the competencies and behaviors, which we outline in the framework, we emphasize what that looks like in terms of effective communication with the patients, with their families, using different tools, adapting to the context, communication with other colleagues towards the provision of care. But we've also interpreted interpersonal in terms of, collaboration, communication, as well as some of the competencies around personal conduct. So yes, you will very much find those reflected within the competencies that enable the performance of all activities. We agree, it's essential.
Thank you, Siobhan. And Reggie, I know you've answered within the chat, but I'd like to really highlight this question that we've gotten from a primary care doctor in the audience. And he asked about mitigating and preventing burnout and departures from service in the health workforce. As Jim highlighted in our initiation, this is an area that really concerns us right now. And so the user says he feels a lot of the challenges, and his concern was that the competencies and potential of workers were not utilized. How would this framework and the competency-based approach make a difference there?
The reason I tried to type the answer was that answering this question will take more than the whole session that is available. When you do a health system assessment, there are when you look at the different building blocks, at least till all of them come together, the services don't get delivered. For example, if drugs are not there, if the number of people available to treat are not adequate, that is going to be a problem. This addresses only a portion of even one of the building blocks. For example, human resource for health, if you need more people, competence is not adequate. But the limited point I was making was that in the assessment that we did, we found that there's a lot of scope for improving competence. We also found that one of the other major intervention, even more important intervention, was that you need adequate amount of appropriate drugs to be available. So other elements have to come together if you have to provide quality care and prevent worker burnout.
Thank you. And what's interesting is we've got a question here from Ibrahim about how WHO was working with health institutions and universities in resource poor countries to actualize this dream. Address, you were very involved in the competency framework. And in fact, I'd like to just tag on to that question. What advice would you offer to an institution looking to update their curriculum? How can we move from the framework to implementation there?
So a very good question. And I would say that I think for institutions that may want to look at revise their curriculum, I think there are good questions that they can use using the framework. Just are you using competency-based outcomes?
Siobhan.
Yes, so yeah, and then of course it's your assessment. So for example, you can look at your assessment. Is it competency-based? Is it oriented to achievement of those outcomes? And then of course, taking your question further, one would be asking, are there right competencies in the curriculum? And then that will enable graduates to transition well from, like theory to practice, or from what they're doing in the classroom, and then when they're out there in practice. So I think once those people who want to review their curriculum find that there are gaps, this is the best time, and I think a great opportunity to use the framework as a reference, because then they'll be looking at what is it that is being offered, and then what outcomes are out there, and then of course getting feedback from the graduates to say, no, I think perhaps we needed to have added this in our curriculum. And I also think that it is also important for organizing, the work. So you're looking at health needs of the population at the center. Also remember, it's not just about people going through education, training. It's about, are we meeting the needs of the population? At the same time, are we also able to manage the healthcare system according to our context? So a great opportunity there, but the framework does help you look at, supervision, scope of practice, different education outcomes, and then standards. So that's all in there. The framework has got all those issues, and I think it would be a very good opportunity to look at the whole program, whatever program you're looking at, and then looking at, does it align very well to the outcomes, learning outcomes, and of course assessments, and then looking at even issues of community involvement that have been ignored many times, swept under the carpet, but we want to make sure that the community is involved. So a great opportunity. The framework does have all that provision, and I would really encourage any institution that would want to revise even their own curriculum to say, hey, there's a framework here as a reference. Look at the framework, and it can actually guide you to improve the curriculum. At the end of the day, we are talking about quality improvement and then for UHC. Thank you.
Absolutely. Siobhan, I'm going to give you a 1-minute question that, just to encourage everybody who's participating today, we will be holding additional webinars on this very important topic, particularly focused on connecting technical specialists. And we certainly will be looking at all of the Q&A, forwarding those to our panels, and including them in the question and answer on our website following this. Siobhan, the competency framework looks at an educational pathway of 12 to 48 months. What about other groups of health workers or short training programs?
Super. Actually, thank you so much for asking this question. We very much developed the competency framework through the lens of the health worker groups, so 12 to 48 months pre-service training pathways, mainly because we found that there was a lot of overlap in their different roles. However, they are only part of the health team when in systems of supervision, referral to other health groups. So doctors, specialist health workers, and others. But actually, there is a lot in the framework that is relevant across groups. So if you look at the competency model, the emphasis on practice activities, the competencies becoming the standards of performance, that is relevant across all education programs, whether it is a 1-day or a 3-week course, or even what we're offering within WHO Academy, for example. That approach is essential to strengthening the education outcomes and the program. What you might find when adapting from the framework is that there are additional competencies that are relevant to other groups. So guidance is provided in how to adapt it within the framework, but yes, relevant across other groups as well.
Thank you so much for that. We really look at education as the base investment for the health workforce, in addition to other elements. So Jim, with that, could you tie us up? What's WHO looking at next? What's on the global horizon?
Thanks, everyone. Well, I mean, I've watched with great interest the Q&A, the chat, the conversations, the rich experience from Address and Rajiv. And I think clearly 250 people here still with a couple of minutes to go. This is a topic which of critical importance. All the presentations will be available first and foremost, and this is just to emphasize, this is the first of many discussions that we wish to hold with all the experts who've led the work and many other stakeholders around the world, because we really want to try and drive this into implementation. That implementation, as you've heard from the experience in Malawi and India, but also from the work across the expert group, applicable to all income settings, global north, global south, anywhere where we're looking to improve the capacity of the workforce to deliver services. You've heard from Address, we talk about the theory, we'd also talk about the practice, and then the assessment frameworks. You've heard from Siobhan, not just the work that we're doing here, but this model is at the heart of the work on the WHO Academy, and so all WHO's lifelong learning training programs in future will be taking this work further forward. We'll also be developing additional modules and using the same evidence base and experience to populate the competencies for the essential public health functions and emergency preparedness and response. So I'd again point people to our website. We've put it up in the chat and in the Q&A, who.int health workforce. All information will be up on there, but importantly, please, if you're looking for support, if you're from any country setting and you're looking for support, please contact directly your WHO country office or your regional office, or drop us a line in Geneva, and we will put you in touch. We really want to take the value of this work, the value of the experts' contributions into practice, and your support, all of you, will be essential to take that forward. Let me just say thank you to Rajiv and thank you to Address for all the work, the expert group, Siobhan, and all in our regions and country offices for the WHO inputs. And Catherine, thanks today for helping us stay on time.
It was a delight to be with all of you. I'd like to give a big round of applause to everybody who is involved and to all of those who have participated so excitingly in our discussion. We will be sending out the recording shortly, and if the document is not already up, it'll be up quite shortly. Thank you so much, and we look forward to the next.
Thank you.